part of our academic series, which lies to look into latest evidences with regards to pediatric endocrinology. And as we know that every year there are around over 120,000 articles which are published across the globe. And if we do not keep pace with them, we will get left out. And very important to understand that when we're looking at those articles as to how it should change our practice in a clinical sense. So why do we need to do a literature review? And what we are looking at in terms of literature review is that we want to see whether the journal article that we are reading should be part of our clinical practice or not. So the key questions you will ask is whether the results that the article has published are really valid. Very importantly, they may be valid, but whether they are generalizable to our settings or not. So if you look at some data with regards to 780G, which shows that there is a significant improvement in terms of diabetic outcome, but if your patient cannot afford it, then it may not be generalizable to your clinical practice. We also want to see whether that journal article really represents a new development or it is an incremental phenomena. So whether it is a 0 to 1 or a 1 to 2 sort of activity. So you want to say that if it's 0 to 1, then probably this is something which is path breaking and things will change over time. And ultimately the aim would be to change your practice from that regards. All of you can go and have a look at our website, learning.growsociety.com, in which has got a lot of resources and courses related to pediatric endocrinology. We have got fellowship and postgraduate training programs. We do run a number of postgraduate lecture series. We also run the journal clubs and guideline reviews. Publications are available along with our mobile applications.
Is the use of adjuvant liraglutide and insulin versus insulin monotherapy in closed-loop hybrid systems in patients with type 1 diabetes. This study was published in the Journal of Diabetes Science and Technology in 2016. So again, as we know, type 1 diabetes is a common presentation in our clinical setup. It is defined by, or it is characterized by a beta cell dysfunction, which is well known and which is the principal mode of treatment that is being followed. But what also happens and is often under addressed is alpha dysfunction happening in type 1 diabetes, which results in a blunted glucagon response to hypoglycemia and a postprandial hyperglucagonemia, which ends up causing a faster beta cell exhaustion. The most physiological mode of insulin delivery that is available to us now is the closed-loop insulin pump, which takes care of the beta cell dysfunction in type 1 diabetes. However, frequent episodes of post-meal hypoglycemia and late hypoglycemia are seen even with insulin pump therapies, which needed to be addressed, and that is how the concept of using GLP-1 receptor analogs was considered. Previously, to address these issues, pramlintide, which is an amylin analog, was being used, but again, you need multiple subcutaneous injections of pramlintide. Then came up studies with exenatide, which was also a GLP receptor analog used twice daily. To reduce the frequency of injections, this study was conducted with liraglutide. So the ideal add-on therapy to insulin in the given scenario is something that will reduce your post-meal glycemic excursions, potentiate the action of insulin, reduce glucagon, is easy to use, and has, again, your ideal therapy should have minimal or no side effects. So the one meeting most of these criteria is your GLP-1 receptor analogs. The mechanism of action, if we look at it broadly, is that it increases your pancreatic insulin secretion, reduces glucagon secretion, decreases gastric emptying, and increases your satiety levels, thereby restricting the amount of food intake. So the study was a randomized control trial, open label crossover, done in adults with type 1 diabetes of duration more than 1 year, who were on closed loop insulin delivery system. They had a fairly controlled diabetes with HbA1c of 8.5% at recruitment, had no anemia, weight greater than 50 kgs, no other comorbidities other than hypothyroidism per se, so no cardiac, renal, any other issues. They did include people who were on OC pills, antihypertensive, dyslipidemic, or antidepressant drugs. The exclusion criteria included adults who were pregnant or breastfeeding with underlying malabsorption syndromes and with history of alcohol or drug dependence. They also included subjects who were on therapies that might affect blood glucose levels or their measured values through CGM. So, like people who were on paracetamol or vitamin C or steroids were excluded in the study. This was a short study, 24-hour study that was done, and patients were called on day 1 at 2 p.m. Yeah. And the study was started at 6:30. So their closed loop system started working at 6:30. The doses were decided by their insulin requirements in the last 3 to 7 days. Study A was the control group, wherein your only insulin pump was continued until the study period, that is next day, 9 p.m. And study B received 8 p.m., that is just before dinner, they received dose of liraglutide 1.2 milligrams. And their insulin pumps continued as they would.
So liraglutide was a single dose or via a closed loop system?
Single subcutaneous dose.
They do mention it plus via anyway, so it was a single dose. The upper arm they say insulin plus liraglutide via closed loop.
And insulin via closed loop and liraglutide was a single 1.2 milligram dose. The study was designed to detect a 25% difference in mean area under curve of glucose for postprandial periods. And the sample size estimated was of 16 subjects in the study. So the study included 15 subjects, but the same subjects were crossed over. So 30 was the sample number eventually. It had, again, 5 males, 10 females. The average age was 26 plus minus 5.8 years. And it had no Asian population per se. The duration of diabetes was 14.7 plus minus 7 years with a mean HbA1c of 7.5, and these mean BMI again here was 26.4 plus minus 3. So more like overweight to obese category of individuals were included in this study. What they found was that the level of the blood sugars were lower, especially
prandial rise was lower.
Prandial rise was lower with the liraglutide arm compared to the control arm. And even if you look at the mean area in the curve, it was statistically significant for the breakfast period and the lunch period between the two arms, with lower blood sugar levels in the liraglutide arm.
So liraglutide was given at what time? Night, evening?
8 p.m. the previous evening. And this is the next day, 3 meals.
So by the time the effect is gone?
Possibly it is.
Next dinner.
Yeah, yes, so next dinner.
Slightly explanation. You see a biggest impact on the breakfast.
Yes.
Then you have the impact on lunch and then dinner. So probably it's going off. That's what they're saying. So if you give it as an infusion with that, that could also be a good option. But then the dose will vary. That will be a problem.
The secondary outcome looked at the insulin requirements, which were found to be lower with the liraglutide arm, and the glucagon levels, again, which were found to be lower with the liraglutide arm compared to the plain insulin infusion pump arm.
So basically what you're trying to say is that because you're giving a GLP-1 receptor analog, you've got a decreased gastric emptying. You've got lower amount of glucagon. That's why your postprandial rise is less. So which makes sense because now when we talk about giving basal insulin also, we are combining it with GLP-1 receptor analog. So these are the concepts we are coming up on that.
The GLP-1 receptor analog arm did tend to have side effects, especially in terms of nausea, GI symptoms, which was managed with ondansetron. The episodes of hypoglycemia were comparable in both arms, but not statistically significant, and there was no episode of severe hypoglycemia. But most of these hypoglycemic events were in the morning, and this was again probably due to the nighttime administration of GLP-1, and maybe switching it to the morning would have reduced the incidence of morning hypoglycemia and provided a more controlled glycemic profile at dinner time, where it was not found to be statistically significant in this short study. So while in the short 24-hour study, liraglutide was found to be statistically significant in terms of lowering the prandial glycemic variability and reducing insulin requirements.
So
We
this
might
is more
need
likely which phase of study you will put it to?
preclinical.
So it's not really, it's more like a dose
Yeah.
finding impact. This has to be a bigger study in terms of that, but it does hold promise in that regards. So thank you. So what it basically tells us is that if you have somebody who is overweight or obese, if definitely if somebody is obese, then adding GLP-1 receptor analogs will help. There are a lot of studies which have looked into the impact of GLP-1 receptor analog in type 1 diabetes, and they have shown that they do improve the weight predominantly by few kilograms with a mild impact on HbA1c. But this is a concept which has been studied in a better way, I would say, in this study. But this definitely needs more evaluation in terms of long-term use when you say everybody should get a GLP-1 receptor analog along with that. So Dr. Vikas is asking, do we stop basal insulin during the study? So this was an insulin pump. So there was no basal insulin there. So they were closed loop system. We can achieve post-prandial uremia proper bolusing. Do we need newer agents with pump as adjunct therapy? I think this is a novel concept. And so what they're trying to do is that somebody who's doing pretty well, they were all 7.5 was the mean HbA1c. Now the aim is they want to go below 6.5 or below 6. So that is a sort of a scenario. That's why they're talking about. So I would say if somebody is obese and somebody is having problems in terms of fasting, postprandial hyperglycemia. In that scenario, this could be an agent which may be considered, but this is not a sort of a significant primary agent in terms of treatment, and it's just an add-on to insulin in that scenarios.